so much, Rajmohan sir, for giving me this opportunity. Good evening to all the senior pediatricians in this room. I guess I may be the only obstetrician. At the very beginning, let me say that I actually have been thoroughly impressed with the kind of detail you have done. I have been sitting on at 2, 3 of your meetings, and the kind of work that you have done. And as somebody had said earlier, the hours that you spend on this are really very expensive. I must congratulate the team for putting up such a great job. The task that has been given to me is what really does the gynecologist have to do, or what is the mother component to the MBFHI? I think I'd like to rewind to 2003 or so, when I was working with Piley sir on the Baby Friendly Hospital Initiative, and we had a mother component there as well. And we used to travel across the state. I remember doing South Kerala with him. And we were talking a lot about breastfeeding, mother preparation, medical disorders. And then came, some people just lead you on to something. Then for me came the interest in antenatal classes. And it has been from 2003 till about 2016 that I have been trying to get this implemented for this. But there were rather many hurdles to this in our hospital. But thanks to the Lakshya program by the government of India, it became mandatory to have these antenatal classes. Personally, I believe that very many of our women, though Kerala is highly educated, women literacy is very high, very many of them are a highly educated but domesticated lot, the ones at least who come to the government setup, and know nothing about either pregnancy, how to tackle it, and how to go about the postnatal period. I often joke and say they never know where the baby came from and where it is going to come out of. Then when we started taking, past 5 years I've just come back to SAT. I was in Paripalli, and we started off the antenatal classes there. I can talk from my experience there that it was a very well received system. That is, the antenatal classes were a very, we used to have groups of women. It is very important that we structure these classes very well. So when I say structure these classes, we must have, every woman must go through 2 such classes. So she must do one in the first 4 months, and she must do the second one in the last 4 months. Because the kind of things you talk about at these classes are very different. I'll come to what we'll talk about. So it's important that she attends to, if you look at it in a broad perspective, at least one. Initially, we started off these classes. I had great hopes for them. And I realized that it is just, the dictum that knowledge is power is so really true, because these women just lapped up those classes. I'm talking about a government setup. They used to come with their bystanders. They used to listen to the classes. They ask hundreds of doubts. And then we started seeing, for me, a big change in our cesarean section rates. They really started to dip. So we started making a seal, that is, the rubber stamp kind of thing. Their antenatal cards would have a seal, antenatal class 1, antenatal class 2. So I'm saying, not just for us to know that they've had a seal, if somebody wants to study at a later date, that, these are the number of people who have had classes, what was their pregnancy outcome, how many of them breastfed within 1 hour of birth, how many of them were able to sustain. We need, data is the next power. We need to know where we are going wrong and where we are doing right. If we don't have data, we can't go forward. So for that, we need to have a seal. And we have a huge, I'll rewind most of you all to your undergraduate days. We have a huge labor record, or what is called the OR book. That OR book today it's now designed by the KFOG. And for all hospitals, whether private or government, there is a separate entry in the OR record for antenatal class? Yes or no? It is that important today. So we need to make it a team effort, and we need to make it as interesting as possible. It shouldn't be something that you just take and walk off. No, I have to do this. I have to put a seal on her record. So let me just finish 15 minutes and walk off. No, you need to keep aside half an hour for it. You need to work as a team. The team must have an obstetrician. Ideally, must have a nurse educator and a pediatrician as well. And you need to have a fixed hour or a fixed half an hour for that. You can set aside, if your OP is on Thursdays or Fridays, half an hour. So take the point at time when the OP is the maximum. In SAT now what we do is, I do it at about 9 to 9:30 because the early ones have come. The late ones will come only at 11, but they're very few. And once they hear that there is a class like this, next time they'll come early. And you just target. I actually stand in the, now our OP is conducive to learning. So we have a lot of space. You just stand over there and just take the class. You don't need to have a PPT. I would recommend that you don't have a PPT. Rather, you talk to them on a one-to-one basis. And later on, when they, if you work in a private setup, you can have or even in our government setup, a TV in the antenatal OP where you can play the antenatal classes for them to watch as they wait. But your antenatal class per se can be a one-to-one class. And who should actually attend this class? Is it only the woman? Definitely not. As part of the Lakshya program and as a part and parcel of how many of us have gone through labors as well, we must understand that we are all good clinicians. We can manage most emergencies. We worry about patient safety, but we are not very good on the ethos side. So we don't have too many kind words for patients. So you can't expect the doctor to be a companion for the patient. It's just not possible. One, because of the caseload. Two, because we are busy doing hundreds of things. This is way back in 2003, we conducted a study in SAT hospital amongst the patients in the labor room. And they said that the labor room was the most loneliest place for them. There were hundreds of people. There were house surgeons, there were postgraduates, there were doctors. Yeah. They were all very busy. But nobody had the time to spend 5 minutes with them, tell them what was happening, how many more hours in labor will there be, what are the findings of the vaginal examination. This was not communicated to them. That's when we realized that we need a birth companion. And a birth companion can do wonders, not just for us, but for the pediatricians as well, because they will support the mother. A pat on the back, helping her to walk, giving her enough of water, taking her to the bathroom, bringing her back. I must tell you what we did in Paripalli. We used to teach, see, most women when they come to the antenatal OP are worried about labor pains. And why am I not talking selfishly from the gynecologist perspective? A painless labor or a well-conducted and a pleasurable experience for the mother will also help her to breastfeed as early as possible. So this birth companion is taught how to actually massage the patient's back. What they often do is they say, Molem, and most patients, I must tell you, I was very happy to note, they said that, my mother has BP, she has diabetes, she can't be my companion. I said, no, she doesn't need to be. You can have your younger sister, you can have your friend. But as of now, even though we have partitions between the beds, we have not started allowing the husbands inside. We had a little bit of a problem when we started. There were mobile phones being brought in, so we just banned the husbands for some time. We will progress there when our husbands become more knowledgeable and when our partitions become more stronger. But as of now, the female bystander is allowed inside, and she's taught to massage her back. Now, this massaging, we attended a course in Hyderabad, and they told us that your simple chapati rolling pin that you use to partify the chapati, that rolling pin can be put in the sterilizer, make it a little warm, just put a little bit of oil, all very simple things, very, very cost effective, and just roll it on the patient's back as she's in labor. And any position in labor helps. It doesn't need, lying on the back is the worst position in labor. She can adopt a sitting position, she can stand, she can walk, provided medical conditions allow her to do the same. So these were some of the modifications we brought out in the labor room in Paripalli, and I must say that the upright position helped the head to descend and helped a lot more vaginal deliveries than what we saw earlier. So it is important to get another person along with the mother. It could be her own mother, it could be her sister, it could be her friend, but whoever she chooses must continue to be there for that time. That is, she just can't come for one antenatal OP and then not come at all. She must come for the next antenatal class as well and must be her companion in labor. That is important, and at least in the labor room in the immediate postnatal period. That is extremely important, because an uneducated person is very difficult. Uneducated, when I say educated in the antenatal classes, is a person who does not know our philosophy of being clean, of washing your hands, washing your legs, changing into a white dress, making sure that you don't, wear old clothes for 24 hours and then not have a bath and handle the baby. All these are taught in the antenatal classes, and therefore the one who comes to them in labor must be the one who has attended the antenatal class as well. So what do we talk? We don't talk just breast care and breast support. We talk a lot of other things. This is just one thing that we talk about, but we tell them what to bring with them when they come in labor. They must have enough. Here in SAT, we have a white munda and a white blouse. We tell them to have, they don't need to come here and run around and buy it. It's everybody has mundas at home. So 5 sets of white, neatly washed mundas, the blouses, the long blouses. Actually, I always prefer, even in Paripalli, to have a front open blouse, because it encourages and it makes feeding much more easier. We also tell them what is their antenatal diet, what all to eat. They always ask. The most frequently asked question, if you were to ask me, was, can I have pineapple? Can I have papaya? It's not that they have pineapple and papaya every day, but it's just their curiosity. And I think we need to cater to it. We tell them that, as far as we know, doesn't cause any abortion. But if you feel that it causes a problem, don't have it. So these are very many of the things. Medical disorders, we tell them what to be careful of, what is a diabetic diet. Then we come to breast care, breast support. So we tell them, as pregnancy advances, you must use a proper breast support. It is extremely important to change the size of the clothes that you wear. You must wear comfortable clothing. You must have a bath. And I always draw, I don't know whether it is a very old-fashioned analogy, but very many things in our minds are old-fashioned. So I always say, if any of you have kept cows at home, I'm not comparing you to cows, but if you've kept cows at home, you'll realize that for a cow to give milk at the end of the delivery, the cow has to be looked after well, has to be given a bath, has to be kept in a good surrounding, must be neat and clean. It's the same way with us. It's just that we have evolved and we are now on 2 legs. But it's the same system. So we need to take care of our mothers. We need to wear proper clothing. We need to have enough of water. We just can't, dehydrate ourselves. And we tell them how important breastfeeding. So we actually talk about the nipple and the breast in the first 3 months. And then we come to what breastfeeding is in the last 3 months. So the first antenatal class will take care of, is your nipple normal? Is the breast size? We tell them that breast size does not make a difference. And if it is a retracted nipple or an inverted nipple, you please tell your gynecologist when you see them. When you have a bath, please make sure that you notice these changes in your breast and see if the nipple is getting retracted, to let the gynecologist know. Way back, we used to teach that if the nipple has to be drawn out with a little bit of oil that you use to have a bath. Today, I know that is not really recommended, and therefore we say that if it is there, you bring it to the notice of your gynecologist and she will do the rest. But then they realize that it is important to look at the breasts when they have a bath, They see a 19-year-old girl does not know this. And the 19-year-old girl's mother may be all of 35 or 36 years, who has either forgotten what she has gone through or has gone through the same kind of thing with no knowledge at all. So it is important that we tell them that to prepare the breast for lactation, you need to look at all these things. The last 3 months, we tell them the importance of breastfeeding. We tell them that babies grow well, babies develop well, babies are safe, babies develop immunity. And I always add one that their intelligence quotients, and in a lighter sense, it's always good to take these classes on a lighter note. It's not important to tell them, this is the content of breast milk, this much of protein, this much of lactose. No, you tell them, see, you want your baby to grow up, go to school, do mathematics well, please breastfeed. So it's not that our Indian population do not want to breastfeed. It is, I would say, an honest wrong belief. I always put that in inverted commas, an honest wrong belief that I may not be able to breastfeed. There is nobody to support me. My mother doesn't know what to do. If I can't breastfeed within 1 hour, is there going to be a problem? So these are all worries, and each person is different, so we need to support that. In Paripalli, we used to also have a rag doll, a doll that was the size of a newborn infant, and we used to teach the positions, and we used to hand that baby doll around so that the mother could also hold the doll, and it makes a lot of sense. She knows what the cradle position is, she knows what the football holding position is. And we always say that we don't really very much appreciate that you lie down and feed, but if you've had a cesarean section, that is all right. We teach them the different kinds of positions. We tell them that rooming in is a must, that the mother must be with the baby, must grow with the mother's warmth. And rooming in, it's not that the grandmother holds the baby and takes the baby somewhere else, whereas the mother rests. Yes, rest is important. She must sleep, she must have a good diet, but rooming in is important. We also stress the breastfeeding within 1 hour of birth, because we tell them that if they feed within 1 hour and the milk comes in early, the first 5 days, it's not actually milk. That's, I think, another very important thing that we need to tell them. It's only a clearish, whitish liquid, but that has all the antibodies. It protects against a whole lot of infections, and it is probably what pediatricians and us say as the first vaccination. So the colostrum, we tell them about the colostrum, and we always get a feedback about these classes. So very many of them tell us, we have a drop box in the OPD. They just put that. Sometimes I don't have the time to see it every week. Somebody reads it. The nurse or someone reads it every Saturday, the antenatal classes for the whole week, and they tell us their doubts. I'd be very happy to tell you that very many of them told us that they are disturbed. Antenatal psychiatric problems we found, because they don't come and tell you on a one-to-one basis, because our OPs are busy and they may not be able to talk about it then, but they actually put in phone numbers, and said, I'm having depression ആണെന്ന് തോന്നുന്നു, ഡോക്ടർ എന്താ ചെയ്യണ്ടേ, ആരെയാ കാണേണ്ടത്, എനിക്ക് ആരെയും കാണാൻ ഇഷ്ടമല്ല, എനിക്ക് കണ്ണെഴുതുന്നത് ഇഷ്ടമല്ല, മുടി കോതുന്നത് ഇഷ്ടമല്ല, എനിക്ക് തന്നെ റൂമിൽ ഇരിക്കാൻ. We found so many problems thanks to these antenatal classes, and I think it goes a long way. And I always used to tell the assistants and the others, see, they must feel that you are there for them. So at the end of your class, you say, don't worry, when you come into the labor room, we are there for you. It gives them so much of confidence to say that we are there. We have a very good set of residents, we have a very good set of assistant professors. They will be there, and our nurses are very superior. So much so that very many of the patients in their feedback after delivery said that their best companion was the nurse. And it's a much smaller setup, and therefore nurses were telling them why, next time when we come in the morning for rounds, the nurse will tell us, the nurse in the labor room will say, madam, do you know this patient sings very well? She sings and she feeds the baby. This was all such positive reinforcement, positive feedback. I think that is the kind of environment we must all strive to work in. The intrapartum experience, I don't know how many women are there in this group, but when I take this class, I always ask women to put up their hands, the ones who've had a pleasurable birth experience. Even in the private or in the government, very many women say that, they were well looked after, but they were scared. They didn't know what was happening. So they decided very foolishly on a cesarean section. They told the doctor, no, I can't do it anymore. Please bring the baby out. So I think respectful maternity care is a large component of an intrapartum experience. The environment should be good, but it's not enough if we have a good environment. The environment is just 25%. Even in our old-fashioned labor room in SAT hospital, you can have a lovely environment. The smile matters. Just by smiling, Paisa always teaches the sister and the doctor on duty must welcome the woman in labor with a smile. And I think that smile doesn't cost anything. We're not going to get a salary hike because we smile, but it'll give you peace of mind. So she must be prevented from being tired and exhausted. She must have enough of fluids. She must have, we always worry, if she has a cesarean section, will she, giving her anything, will it hamper? Most of our cesarean sections are done under spinal anesthesia. And if you look at all the international guidelines, they tell you that clear fluids in labor are fine. So she must be well hydrated. I'm talking of all this with the background of the BFHI, but it is also important that the mother is looked after. She must not be tired. She must not be exhausted. She must be hydrated. She must have, we always say that, chewing on a naringa muttai makes a lot of difference. It gives, provided she's not a diabetic, but it gives her some, the saliva is there in the mouth. It's a kind of a sweet experience, or a mint or a polo. Maybe she hasn't. And walking to the bathroom, going and passing urine on her own. I tell very many of them, if you feel like washing your face, combing your hair, brushing your teeth, please do it. In cesarean sections on demand, if you ask me what is my one passion in life, it is to reduce cesarean section rates. I believe very strongly in it. So I think the cesarean section on demand must be discouraged, not just for us, but for you as well, because once there's a cesarean, everything becomes slower. But again, to re-emphasize the point, the cesarean section does not mean that feeding cannot be there for hours on end. Again, this is what the mothers, sometimes I do believe that the patients are all willing to do all this, but the mothers believe that the babies must not disturb the mother. The mother must lie there, must not feed. She will be, singing songs and making noises and rocking the baby who is wailing because the baby is hungry. So we used to feed the babies in the theater, on the table. Once the pediatrician okays the baby is bought. I don't know, Binu is on this group. Binu, that was one of his research projects. He used to make sure that the babies are brought to the theater and put onto the breast. It works. For us, it's a big thing because the oxytocin release will also help in uterine contraction. So that was this thing. And basically, patients, this is the what should I say, the sign that is there when women enter the antenatal OP. Garbham oru rogam alla, garbhaniyal rogigal alla. So this is the kind of thing. Yes, there are medical disorders. 15% of them will have something or the other. But still, we need to preserve pregnancy and labor as normal as is possible. Immediately after birth, fondling the baby, putting the baby to the breast, and ensuring skin-to-skin contact will go not only a long way in nurturing bonding, but will also help in breastfeeding. So everything, I've been telling you a lot of things. It may sound good. Is it practically possible? Yes, it is. Pregnancy is special. Pregnant women need to be treated with love and affection, and they need support and encouragement. This encouragement is a big thing. See, when I still remember when I was a lecturer working in SAT hospital and used to do rounds, all the mothers and the grandmothers on morning rounds will say, Doctor Palilla. And madams, all our senior madams would express the breast milk and say, Da noku idalle karyam. I understand that today that is not allowed, or rather it's not to be done. Sometimes I wonder why, because it gives the woman a terrific confidence that yes, there is milk coming out. But it is for us to encourage these women in the right way to feed, the right kind of support, tell her what position to use, tell her to drink a lot of water. There are a lot of grandmotherly tales that say that, I'm sure the pediatricians know it as well, that if you drink a lot of water after your delivery, vayara chadum. So they embark on the postnatal period totally dehydrated. So we teach that as well in antenatal classes, that the vira will go back to its normal position and its normal size by exercise and not by not drinking water. 90% of breast milk is water, and therefore, unless you drink water, you will have problems. So, lot of reinforcement on nutrition, on diet, and on drinking a lot of water. Ambulation. We are so worried that they will have. We used to think that venous thrombosis was a disease of the Caucasians and not us. Today, you will find that it's our fourth most common cause of maternal death. So we are reaching there somewhere. So we need also to be very strong on ambulation, on hydration, and on feeding. The support that they need is required more postnatally. Antenatally, they need somebody to come with them to listen, to figure out how the bag should be packed to come to the labor room, what all should be there, what are the baby clothes, what should be there, the mundas that have been cleaned and neat and ironed and kept. All that is there, but postnatally, they need somebody. I often, there are very many people, if you notice, the ones who come from the north, that is these migrant workers, when they come to deliver, I always say, look at, it's good to talk about a captain in the postnatal ward, but I say, look at her, she's up and about, she's feeding. It's a lot more different than what our Kerala women do. That's because that comes to them naturally. They have learned that from their mothers. They have seen in an extended household, people are feeding. Kerala is different. We are all nuclear families. There are no grandmothers around, or the grandmothers that are there are not telling the granddaughters anything. So they don't know. Neither does the mother know or the grandmother know. So they need to be taught, and that support is required. Once there is somebody who's active, proactive, postnatally, to help in establishing the feeding and get the mother to have sleep in between, eat something, wash herself, have something nice to drink or eat, and as well to drink a lot of water, that will help her a lot. But is that all that we have? No, we have a lot of problems. Positioning, they don't know how to position. One patient told me last week, doctor, enki rendu kaiye ullu. I said, you need only one hand, don't worry. So it's just the fact that they need to be told how. They don't know positioning. We need to tell them what is the position, whether it is the cradle position. So I always teach, even in the antenatal OP, the head of the baby should be in the crook of the elbow, and the bums of the baby must be in the hand. So one hand is enough, and the other hand is used to make sure that the baby's nose is not getting compressed, but otherwise the other hand can even be free. It's enough to hold the baby in one hand. We teach the cradle position. We also teach latching in the second antenatal class. We tell them it's very difficult. See, when you talk to these women, using terms like nipple will work, but areola, they don't understand. So you tell them the black part must be in the baby's mouth fully. The baby must not suck only at the nipple, because it will lead to problems like cracked nipples, sore nipples, and eventually you may have an engorged breast. So we teach them changing of from one breast to the other. We teach them fore milk, hind milk. I'm not going into this because I understand you all are the masters in this. But yes, how do we manage engorgement? We are the ones who will pick up the engorgement. I was actually speaking to Dr. Indumati about this, and what is it that we find? The engorgement comes mainly due to two reasons. One, either she's not feeding properly, or two, more often than not, it is because the baby has some problem, either sepsis, and the baby has gone into the nursery, or if it's not sepsis, some small problem. So she started feeding, so there's a letdown, the milk is coming in, but the baby is not there. So we need to teach them how to maintain that lactation. So pumping the breast, whether it's a manual pumping, we tell them how to pump from the base downward. Very many of them don't have, I know it is there in the nursery, but very many of them on a personal basis may not have the electrical breast pumps, but yes, that is an option as well. Sore and cracked nipples is a very frequently, what should I say, very difficult also, because patients say, Doctor, I understand that perfectly. Very many people have very low thresholds for pain, and I don't really think so. If you can take these antenatal classes and tell them that it's not the nipple the baby sucks on, but on the areola, and you teach them the correct method, this usually will not happen. There are methods we use. There are ointments like Nip Care and all these, which eventually they are told to use. But we tell them to, the breast doesn't need to be washed all the time after the before the feed, but at least wipe off all the ointment before you give it. Or we tell them to apply the breast milk itself onto the nipple for the cracked nipples. Sick mothers, especially in the ICUs, who've had severe hypertension, who've had obstetric hysterectomies, may not always be able to feed. But if they're not on ventilators, that I think would be the only reason why they breastfeeding will be a little delayed. We tell the bystander to take the baby in, feed, and bring the baby out. So sick mothers are also postnatal. I think the most important, usually when all of us do rounds, the last ward we go to is the postnatal rounds. And I think that's probably the most important one. So you need to check with each patient, ask, is the baby sleeping well? Have you been sleeping well? Have you taken some rest? Have you drunk a lot of water? Have you eaten well? It just doesn't mean that you know what is happening, but also the fact that the mother feels happy with the kind of care she's getting. Just observe the feeding techniques, help sort out issues while you're there in the ward itself. I always, once I'm there through half the ward, I just stop in the middle and take a class. 5-minute class. How they need to take iron and calcium for 6 months. How breastfeeding is so very important. It has to be maintained for 6 months as an exclusive breastfeeding policy. How all mothers will be, you need to tell them that all mothers will be able to breastfeed. If you have any problems, there is a sister, there is us, please contact us. So whenever we write, house surgeons will write mother and baby well. You really need to check whether the mother and baby are well at discharge. The 6 weeks postnatal checkup, we always tell the mother when she goes home that she needs to continue to maintain lactation. We always talk about night feeds. That's because not only does the letdown reflex is better in the night, because prolactin is also, it has a circadian rhythm, but more than anything else, for us, breast milk feeds more in the night also means prolonged amenorrhea and better contraception, using lactational amenorrhea as a contraceptive method. So at the 6 weeks, unfortunately now with COVID, all this is not there. We don't even have a postnatal clinic. It's not functioning because they all go to the local hospital. But I'm sure every hospital must be able to do this. The 6-month exclusive breastfeeding policy must be reiterated at that time. And they need to know the baby's weight. They need to be told the baby is growing, that the baby is getting enough of milk and the baby is fine. And definitely we need to encourage contraception. I think that's my last slide. Thank you very much. I'm willing to take any questions.
So the learning objectives are to understand 10 steps as quality improvement process. This is very important. This has been undertaken, conceived as a quality improvement process, whether you like it or not. So there are certain stringencies, there are certain rigor expected in that. There are certain expectations in that direction. And it is conceived as a continuing program of the government of Kerala as a quality improvement process. They have a continuing program. Lakshya is one of it. So to learn the differences and modifications, the revised BFHA policy. We have been always talking because we are all old Buddhists. So we are more familiar with the old policies. What all changes have happened? We have to do an honest inspection. Then explain stepwise implementation and the global standard. This is very important. Global standard is very important. I don't yet know how Amjit is making the standards. They have given us some cues, but still I don't know. I'm not sure. So I thought it is better that we discuss about global standards here, global standards by WHO. And I have copied the slides of WHO, the generic global standard slides I have copied. And it is usable by everybody. So there is no issue of copyrights. So today's class is to understand as a quality improvement process, learn differences and the new guidelines or policy, and explain the step-wise implementation, especially regarding the global standards. So you have to now discuss little SPM, because it is important. What is policy? Policy, everybody is saying about policy. Policy has different purposes. One is that it gives us a confidence and gives an assurance, and we are certain that we are in the right direction. So it is a corrective purpose. Policy always has a corrective purpose. And it is a blueprint for action. And it is a reference page so that we can refer it. It is easy to convince others. Suppose the government of India, people come, observers come, how you have done it, they are inquiring. Suppose UNICEF people come, or as an academic document also. Suppose my students ask me, so policy is important. So that is why WHO and UNICEF has conceived this right in the 1987 as a policy, and they have given guidelines and they are updating it. And it's the basis for planning and implementation. Don't think that policy is only for the state, like health policy, government national policy. Policy is there for every institution, for everybody. So even your institution can have a breastfeeding policy. That is why the model hospital breastfeeding policy you have to develop. And policy is a dynamic document. It is not an inert page or it is document. Policy without action is useless. It is a waste. So it is a dynamic document. It's a continuous activity. And they say about policy cycle. Policy without action is incomplete, and policy has multiple stakeholders, what we call as policy players. Who are all the stakeholders in this policy? We are the stakeholders, the IAP, all the implementers, all the directives, all the external assessors or the evaluators, all who set standards or benchmarks. All these are the various stakeholders. MDFHI program, WHO has conceived it as a quality improvement process. MBHI is a quality improvement process, and policy is the basis for this quality statement development. Quality improvement is a process of improving quality over time. So time is important. It is not a one-time activity. It is you have an inner push to excel. Everybody has what we call professionalism. All of you know what is professionalism. So the basis of professionalism is to excel, and we always try to excel in knowledge, in keeping ourselves skilled, more skilled, and we don't want to create errors and to reduce errors. So that imperative for quality improvement is the basis, and the imperative to excel is the basis of quality improvement process, and the steps are only yardsticks for it. Consider the steps only as yardsticks or only as cues for us. As the baby has cues to be noticed by the mother, these steps are only cues for us to successfully implement the program. And the implementation team is the first important thing. The program is a team activity. Your leadership skills are important, and your positive attitude is important, and mutual respect and values maintenance are important. All elements of group dynamics is important. Facilitate group process or dynamics, communicate and share, where listening skills are more important than teaching skills. So everybody has to behave themselves appropriate to the program and to the success of this mission, and respect time and set targets and endpoints. Do it on your own style and respect. Does not mean that you have to comply to all directions or guidelines. These are only to help you. You have to definitely do it in your own style with innovations, whatever you want. Only thing is you have to enjoy whatever you are doing, and you have to show others as a role model. So after actually the program is halfway, we will be very interested. Actually, we are doing the academic work. We are interested. We are not sleeping after this. We are interested to know what are the best practices, which institutions are the best role models. All these things we will be looking. And finally, we will be also looking into the impact evaluation. And so doing it your own style with innovations and creativity is important. And keep group focused on the present and priorities. Here and now, what I am going to do. That is the meaning of focusing. All activities without focusing is useless, and it makes a lot of waste. Your time is important, your resources, all money is important, and for your hospital, you are the persons to make results. So be focused and focused here and now, and ask what we can do, and make sure group members are on the same page, because the group cohesion is very, very important, and you need to resolve all conflicts. Now, policy elements, policy always has different elements: structure, process, and outcome. Process elements are there. We are more interested in the process element. The first question our health secretary asked is, oh, you are proposing a very good program, but where are your process elements? So immediately within 2 days, we have to make an operational guidelines. It is a draft guideline, but we have made a draft guideline and we have presented it. So whatever they asked, we have presented. Of course, we have presented a lot of things, of which they are not using many of the things, but we are not frustrated because we have learned. It was a learning experience for us. And for policy directives, policy tools, these are important. Policy tools can be advocacy tools, monitoring tools, it can be decision-making tools. For example, the checklist for certification is actually a decision-making tool. Advocacy tools, usually in the program, we have to publish advocacy tools in our sites. And monitoring tools, Bala will be talking too much more about monitoring tools. I'm not going to that. There should be actually our review meetings when it is going. We are conducting the meetings with a structured and with a systematic way. That is a monitoring tool. How to organize meetings and what all things we do in the meetings. All these are monitoring tools. Then policy directives are there. For example, not giving, actually the policy of WHO, it has 3 parts. I will come to that. 3 parts. First part is the institutional arrangements. Second part is the key clinical practices. And third part is the discharge policies. All these things are policy directives. How you make complaints to IMS Act, making best feeding promotion as standard practice, how mother is directed or helped or facilitated to do what thing. So keeping track of support to breastfeeding or monitoring, all these are policy directives. And see, any activity planning is important. In the quality perspective also, planning is very important. Situation, what are the steps of microplanning? Microplanning means what you are doing in your institution is microplanning. And you should have a small hospital policy for conducting this planning, and policy is basis for planning. And situation analysis and identifying local needs, which is called customization. WHO actually set of guidelines are there, and the last guideline is called customization guidelines. How your institution you are doing it, how the global standards and global policy directives, how you are conceiving it, from that how you are abstracting it, how you are making it tailored to your own personal, your own institutional level needs with your limited resources. That is called customization. And talking in a language which your people know, because there are, even Kerala, different places have different slangs and different vernaculars. So how you make it appropriate to their own needs, individualized needs, that is called customization. And sensitizing the influencers is very important. That is we call advocacy function. What Narayanan and Sachi are doing is the advocacy roles. Then prepare facility level micro plans, set targets, set timelines, key points for as process elements, or what are all the activities, important activities to do, prioritization, then internal monitoring, as Bala will be going to talk, and triad of planning, improvement, and control, important for quality improvement process. That is, you are to make a micro plan, and you should all have share the spirit of innovation and spirit of excelling to your own members, and control. You should have control over everything, because if the things goes wrong, you should know where it went wrong and how to repair it at that point itself. That is what is the meaning of control. So this is called a PDSA cycle: plan, act, study, and do. Okay, I don't want too much on that. So preparedness is important. You are the best to say how we are going to prepare. I don't know anything about your institution's needs and preparedness. You have to have a clear plan about. As you are very good hospital, some of you are at least hospital owners or hospital management people who know about your financial plan, and you like that. Here also there is a plan, and setting the environment is important. Transforming the staff towards building competence is important. Preparing the mother for feeding and counseling the caretakers. So this is what how the breastfeeding policy has been developed by WHO and UNICEF. Actually, their source books are very, very comprehensive, very, very detailed, and it contains a lot of management techniques, community public relations techniques, communication techniques, all those things. I have not gone to any of those things because it may be boring to you. I have just given a nutshell of whatever is that and how they develop the policy. Now we come to the standards. Global. This is actually global standards by WHO. 10 steps has revised. How it is. Second part is how it has been different from the older policies. First, most important difference is that they have separated to major two parts. Of course, there is discharge policy also, but these two parts are provided. The first is critical management procedures in the hospital level, institutional level, or facility level to provide enabling environment for sustainable implementation. This sustainability is very important. And key clinical practices which delineate the care that each mother and baby should receive. So what is standardized care that baby should and mother, their dad should receive? What is the standardized? There should not be any disagreements. Until there have been a lot of differences between individuals or professionals in doing it. There were no complaints, but that is not enough. Everybody should do in a uniform way. So that is why they are giving standards. And evidence-based, these are all evidence-based because they have research evidence or scientific evidence to support that. And revision include full compliance with WHO. See, the original policies didn't include the WHO IMS code. Even though the WHO IMS code was there from 1990 onwards, this was not incorporated into the policy, 10 steps. So they have not only incorporated, they have placed it first. And need for ongoing internal monitoring of adherence to the clinical step. This is also included in the first step. That was not mentioned at all. Then what are the other differences? Small differences are there. Step 2, there is more emphasis given to competence. Step 5, there is more emphasis on how to facilitate and give support rather than more emphasis on expression of milk and things like that. So there is a lot of flexibility in that. Supporting mother support, there are a lot of flexibilities. And step 9 also gives previously, my own teacher, Sunay madam, used to do her rounds, and madam used to look for this feeding bottle, and immediately she used to throw it away after she has come from this BFHI trainings. And actually, we used to say ban, total ban. Now they are not saying about ban or anything. They don't mention that, but they are saying that instead of that, they are saying completely prohibiting it, and personnels are required to be facilitated to do that. So there is a lot of directives or guidelines how to remove that phase by phase with the help of the IMS Act. And on post-discharge care also, that has been mentioned as a responsibility of the provider, because they have to contact the community settings, and they have to contact the health worker, peripheral health worker. Actually, there are certain internationally, they are reported that there are certain legal suits came after that, because the hospital authorities have not, the hospital team has not contacted the peripheral person, and so there were problems of breast engorgement and abscess and things like that. So they have sued for their referring institutions. This has happened really, and there are case studies on that. Case studies explaining this. So this should not happen. So this is now the policy is not a law, but this can be quoted in the court also. So the marketing of breast milk substitutes, what are the standards now? So we have discussed the differences, and now we come to the standards. What are the standards? I will just rush through it. These are the global standards. That is the standards preferred by WHO. So first, the first A, B, and C, the steps, and whether the facility have purchased it or not, facility has displayed it or not, and whether the facility has a policy, how it describes how it is complying to the IMS Act. And at least 80% of health professionals who provide antenatal, natal, and postnatal care should be able to explain at least 2 elements of this. I don't know how Amjit is going to, how much titration they are going to do, make all these things standards, but I am giving you the global standards so that you are tuned to discuss that. And 1B, these are the health facility has a written infant feeding policy, and the policy is visible. They are in line with BFHI standards, and at least 80% of clinical staff who provide antenatal delivery and newborn care can explain at least 2 elements of this infant feeding policy. അതാണ് WHO standard ആയിട്ട് വെച്ചേക്കുന്നത്. Monitoring and data management systems, a protocol should be there for that, and the committee should have met at least every 6 months. And staff competency, അതിലൊരു specific 80% ഒന്നും പറഞ്ഞിട്ടില്ല, at least 6 months എന്നുള്ളതേ പറഞ്ഞിട്ടുള്ളൂ meeting. Staff competency, at least 80% of health professionals who provide antenatal delivery, and they should be able to report these things. And also 80% of health professionals who provide the care should have done competency assessments or refresher training once in 2 years. അത് അവരും ഇങ്ങനെ ആയിരിക്കും. റീസർട്ടിഫിക്കേഷൻ എനിക്ക് തോന്നുന്നു അതിന്റെ ബേസിലാണ്. എവറി 2 years ആയിരിക്കും. 3 years വേണമെങ്കിലും ആക്കാം. ഓരോ രാജ്യങ്ങളിലും ഓരോ രീതിയിലാണ് ചെയ്തിട്ടുള്ളത്. At least 80% of health professionals who provide antenatal delivery and newborn care are able to correctly answer 3 out of 4 questions. So sharing the antenatal information, sharing the information about support baby-friendly hospital promotion with the mothers. Protocol for annual discussion is important, as Sangeeta was saying. Global recommendations have given certain content points that is important, and the importance of immediate and sustained skin-to-skin contact is important. Early initiation of breastfeeding is important. This is actually how they make something mandatory. ഈ പറയുന്ന 4 എണ്ണം, skin-to-skin contact, initiation. പക്ഷേ ഒരുപാട് റിസർച്ച് കഴിഞ്ഞപ്പോഴത്തേക്ക് ഒരുപാട് പേപ്പേഴ്സ് വന്നിട്ടുണ്ട്. ഹൗ ഡിഫിക്കൽട്ട് ഇറ്റ് ഈസ് ടു മെയിൻറ്റെയിൻ ഇനിഷിയേഷൻ, 100% ഇനിഷിയേഷൻ. അങ്ങനെ ഒരുപാട് ഇതിന്റെ ആക്ച്വലി ദർ ആർ ലോട്ട് ഓഫ് ക്രിറ്റിസിസംസ് ആൾസോ. അങ്ങനെ കുറെ സ്റ്റഡികൾ വരുന്നുണ്ട്. എങ്കിലും വി ഹാവ് ടു മേക്ക് എ യാർഡ് സ്റ്റിക്ക്. 80% എത്രയാണെന്ന് എനിക്ക് അറിയത്തില്ല. ബട്ട് ദീസ് തിങ്സ് ആർ ദ മാൻഡേറ്ററി തിങ്സ്. Now, at least 80% of mothers who received prenatal care in a facility report having received prenatal counseling, and 80% are able to adequately describe what they have discussed. കിട്ടിയെന്ന് പറഞ്ഞാൽ പോരാ, എന്തൊക്കെയാണ് അവർ കിട്ടിയെന്നുള്ളത് അവർ പറയണം. 80% of the mothers report that their babies were placed to skin contact for at least 5 minutes. 80% of mothers report that their babies were put to breast within 1 hour. That's initiation. Then global standards, 80% of breastfeeding mothers to term infants report that someone of the staff offered assistance, and 80% of mothers report having been helped to express breast milk, and 80% of mothers demonstrate how to position the baby. അത് പറഞ്ഞു കൊടുത്തിട്ടുണ്ട്, അവർക്ക് ചെയ്യാനും പറ്റി, അവരുടെ എക്സ്പീരിയൻസും പറയണം. At least 80% of breastfeeding mothers term infants describe at least 2 ways of facilitating milk production for their infants, 2 indicators of whether a breastfeed has consumed adequate milk. നമ്മൾ ഇതൊക്കെ ഒരുപാട് കാര്യങ്ങൾ പറയുന്നതാണ്, ഓരോ ക്ലാസ്സുകളൊക്കെ ഇഷ്ടം പോലെ എടുത്തതാണ്. Actually 4 or 5 indicators we have mentioned. At least the mothers should say 2 indicators. At least 80% of mothers of breastfed preterm and term infants can correctly demonstrate or describe how to express breast milk. അത് സംഗീത പറഞ്ഞതാണ്. Supplementation, 80% of infants received only breast milk throughout their stay at the facility, that the staff discussed with them, and staff discussed with them the safe preparation, feeding and storage of breast milk substitutes. As a substitute, ഇപ്പോൾ ഒരു 100% substitute ഇല്ല പക്കത്തില്ല. Whenever there is medically indicated, it should be done, and they should be taught and shown how to do that. And step 6 നെ പറ്റി documented medical indication for supplementation, and as far as possible 80% of situations the mother should know that there is a human donor milk, and that facility should be there. So rooming in practice, it is very simple. 80% of mothers in term infants report that their baby stayed with them and without separation more than 1 hour. Observations in the postpartum ward and well baby observation areas confirm that at least 80% of mothers and babies are together, and 80% of mother of preterm infants confirm that they were encouraged to stay close to their infants day and night. And responsive feeding, at least 80% of breastfeeding mothers of term infants can describe at least 2 feeding cues. ഒരുപാട് feeding cues ഉണ്ട്. Actually, I was discussing with Indu which are the best feeding cues. Actually, turning the head, opening the mouth, hand, bringing the hand to the. Actually, the mothers are the best persons to recognize it and tell us. They are the best teachers. So at least 2 they have to say. And then at least 80% of breastfeeding mothers of term infants report that they have been advised to feed their babies as per the demand. Or പണ്ട് നമ്മൾ ഡിമാൻഡ് ഫീഡിംഗ് മാത്രമായിരുന്നു പറഞ്ഞുകൊണ്ടിരുന്നത്. ഇപ്പോഴാണ് ഈ റെസ്പോൺസീവ് ഫീഡിംഗ് എന്നുള്ള കൺസെപ്റ്റ് വന്നത്. ഇത്രയും നാൾ എങ്ങനെ ഇതൊക്കെ നമ്മൾ അറിയാതെ പോയി എന്നുള്ളതാണ് എനിക്ക് ആസ് എ പെഡിയാട്രീഷ്യൻ ഹൗ വി ഹാവ് മിസ്ഡ് ഇറ്റ് എന്നുള്ളതാണ് ഇപ്പൊ ഇവർ ഇതൊക്കെ പറയുമ്പോൾ മനസ്സിലാവുന്നത്. പക്ഷെ ഇതൊക്കെ നമ്മൾ ചെയ്യുമായിരുന്നു. ഇപ്പൊ ഇതൊരു പോളിസി ആയിട്ടൊക്കെ പുസ്തകത്തിലൊക്കെ എഴുതിയും പേപ്പറായിട്ടൊക്കെ വന്നപ്പോഴാണ് നമ്മളത് കൂടുതൽ ഡിസ്കസ് ചെയ്യുന്നുള്ളതേ ഉള്ളൂ. വി ആർ ഡൂയിങ് ആൾ ദീസ് തിങ്സ്. ആർക്കും അറിയാൻ പറ്റുന്നത് കൊച്ചുങ്ങള് കൈവായി കൊണ്ടുവന്ന് പാല് കുടിക്കാൻ വേണ്ടിയാണെന്ന്, അല്ലെ മൗത്ത് ഓപ്പൺ ചെയ്യുന്നത് പാല് കുടിക്കാൻ വേണ്ടിയല്ലെന്ന്. So feeding bottles, teats and pacifiers, absolutely no. 80% of breastfeeding mothers of preterm and infants report that they have been taught about the risk of using it. Actually, ഇതൊരു മാൻഡേറ്ററി ആയിട്ട് എനിക്ക് തോന്നുന്നത് അംജിത്തും പാർട്ടി എടുക്കുമായിരിക്കും എന്നാണ് എന്റെ വിശ്വാസം. കെയർ അറ്റ് ഡിസ്ചാർജ് ഇസ് വെരി ഇമ്പോർട്ടൻറ്റ്. ഇനിയിപ്പോൾ നമ്മുടെ ഇവിടെയും ചിലപ്പം ഡിസ്ചാർജ് സമയത്ത് വേണ്ട രീതിയിൽ അവരെ എഡ്യൂക്കേറ്റ് ചെയ്തില്ല, വേണ്ട രീതിയിൽ ഡോക്യുമെന്റ് ചെയ്തില്ല എന്നുള്ളതിന്റെ ബേസിൽ ചിലപ്പോൾ സ്യൂയിങ് വരാം. So at least 80% of mothers should report that somebody has, they are ensured that they have access to breastfeeding support in the community, and the facility can demonstrate and coordinate with community services. പക്ഷെ അതിന് കമ്മ്യൂണിറ്റിയിൽ ഫെസിലിറ്റി ഉണ്ട്. ഇപ്പം പക്ഷേ ഗവൺമെന്റ് ഫെസിലിറ്റി എല്ലായിടത്തും ഉണ്ട്, എല്ലാ കമ്മ്യൂണിറ്റിയിലും ഗവൺമെന്റ് ഫെസിലിറ്റി ഉണ്ട്.
So good evening, everybody. NNF Kerala considers it a proud privilege to be associated with this great program. So I have been asked to speak about the babies who are in the special care nursery with problems like prematurity, low birth weight, etc., etc. Such babies are fed as per the following guidelines, like kangaroo mother care, non-nutritive sucking, expression of breast milk, palatal and tube feeding, and the donor express breast milk. Breastfeeding in preterm and low birth weight babies is a challenge for both mother as well as the baby. As far as the mother is concerned, preterm delivery adversely affects lactation, initiation, incomplete growth and preparation, low levels of placental lactogen, lactation by stress, fatigue, and anxiety. Mothers of preterm can achieve successful lactation by frequent milk expression schedule in the early postpartum period. Average baseline milk production by the end of first week is high of adequate milk volume at 6 weeks postpartum. So mothers of extremely preterm infants should be taught the expression techniques as a matter of urgency. Yeah. And now coming to the challenges for the baby. The direct breastfeeding may not be possible in most of the low birth weight and preterm babies. They may be unable to suck effectively. To coordinate sucking and swallowing and breathing becomes a big challenge. Some of them may be requiring respiratory or cardiovascular support. So methods to promote lactation in NICU babies. Of course, the kangaroo mother care, non-nutritive sucking, and expression of milk. Kangaroo mother care is the best method of holding an infant in an upright and prone position, skin to skin on mother's chest for a period of time. Clothing and blankets are wrapped over to provide a secure kangaroo-like pouch. This helps to promote lactation, better bonding with the baby, greater ability to understand feeding cues of the baby, and the thermoregulation. Non-nutritive sucking. Any sucking that the infant will do without milk transfer, usually given at empty breast after expressing milk. This improves coordination and muscle tone, calms the infant, assists transition to oral feeding, and better milk output. Now, expression of the breast milk. What the technique has to be taught to the mothers. Wash your hands well with soap and water. Place a clean container below your breast to collect the milk. Massage the breast gently towards the nipple. Place your thumb and index finger opposite each other just outside the areola. Now press back towards your chest, then gently squeeze to express the milk. Repeat the step 5 at different positions around the areola. Expression of the breast milk, the mechanical help is the breast pump. There are two types, one being electric pump and the manual pump. The manual pump is small and portable, doesn't need any electricity. Your body might respond better to a manual pump. It provides quick relief for engorgement of the breast. It is quick and easy setup and much cheaper. Express breast milk storage. In room temperature, you can store express breast milk for up to 4 to 6 hours. And if it is refrigerator, up to 24 hours. And if the freezer is used, even up to 3 to 6 months. The points to remember in expression of breast milk. First milk expression should be as soon as possible following delivery. The amount produced can be as little as few drops of colostrum at each expression for the first 24 to 48 hours postpartum. Assure the mother that no amount is too small to save for the baby. And mothers should be encouraged to express at least 8 times in 24 hours, that is 10 to 15 minutes per breast. Now, coming to the methods of feeding in preterm in a nutshell. Based on the gestational age, maturation of feeding, the skills and the techniques involved. Baby less than 28 weeks, the sucking will not be developed, no propulsive motility in the gut. Such babies are put on IV fluids, intravenous fluids. 28 to 31 weeks, the sucking bursts develop gradually, but no coordination between sucking, swallowing, and breathing. So we prefer orogastric or nasogastric tube feeding with occasional spoon or palatal feeding. It's still better from 32 to 34 weeks when slight maturity of sucking pattern develops, coordination between breathing and swallowing begins. It is then that we introduce spoon or palatal or cup feeding. Over 34 weeks is much better. Babies mature the sucking pattern, more coordination between breathing and swallowing. That's when you commence breastfeeding. Now, the palatal feeding and the tube feeding. The trophic feeds are started in small quantities by NG tube. 10 to 20 ml per kg per day of express breast milk is given to a baby who is not capable of tolerating the total required quantity of EBM. They help in maturation of the gut and liver function. The donor express breast milk. In rare circumstances, when mother's own milk is unavailable or insufficient grossly, the next best option is pasteurized donor human milk. Fortunately, we have 2 milk banks in Kerala at the moment. One is at General Hospital, Ernakulam. Second one is at Jubilee Medical College, Thrissur. Establishment of feeding in preterm. We start with early pumping of breast milk, pumping 8 to 12 times per day, then adequate diet and rest for the mother, skin to skin and non-nutritive sucking, and of course, the most important thing is counseling. We give all support to the mothers and give them all timely intervention to help them out during this trying periods. Then still if the breast milk is not adequate, we use the galactose. How can you establish lactation for a preterm baby in an ICU? And when and how frequently will you express breast milk if the baby is admitted in an ICU? How long can you store EBM in room temperature? These are questions to ponder.
Thank you. So in the next 10 minutes, I will just try to give you an overview of the why do we need a human milk bank as part of the NBFH 5 program. So to begin with, let us just recap just what we have been, you have already heard so far. Like India is the biggest contributor, highest global burden, be it the number of births 20%, or the number of low birth weight babies 38%, or the number of preterm babies 23%, or the number of neonatal deaths 29%. And now we know, we come to a area where we now know that any intervention that you do should be cost effective. So you can't do high tech interventions to save too many lives. It is practically not feasible. So the current trend is to use cost effective and feasible interventions. And we have enough evidence now to say that 75% of the preterm babies can be saved with these interventions. Basic interventions like breastfeeding, kangaroo mother care, thermal protection, and the such things are the ones that are going to save preterm births. So now this is part of the same, the breast milk bank requirement is probably in the same thing. Little bit about history. Of course, we all know Brazil is a country that has been credited with a dramatic, magical reduction in its infant mortality rate once the breast milk banks were established. And it has the largest network of breast milk banks as of now, 217 banks. And they are working quite effectively. If you look at the published literature, theirs is the best system as far as the networking of breast milk banks is concerned. As far as Asia or India is concerned, we all know the first breast milk bank was established under the leadership of Professor Armida Fernandez in Dharavi, Mumbai at Sion Medical College, Mumbai. And then thereafter, from 89, there have been so many medical breast milk banks in our country. In a survey published by Ruchika Sachdeva and group in 2019, they identified 22 licensed human milk banks across India, which were operational for more than 1 year. Because what happens, some of the breast milk banks open and then shut. So any breast milk bank that was open, functional for more than 1 year, 22 banks were identified, and they conducted a survey. 16 of these responded, and they found that the real scenario in India is not very rosy. Certain centers like Mumbai and all, they do very well, but some of the centers, it's very, very pathetic. Percentage, if you are going to see, 69% of these were in the government charitable hospitals, 12.5 were established exclusively with government funding, let's say public public-private partnership, and then 50% only had a dedicated technician. And if you really want, you need every shift there is a lactation counselor should be available. So only 6% of these, only one bank had more than 5 lactation counselors in this. So this is the reality in our country. In our state, unfortunately, we never had a breast milk bank until this year, despite the increase in number of artificial reproduction technology and the higher burden of preterm and very low birth weight babies. So we were totally banking on the formula feeds, because we all know MOM, mothers on milk is the golden rule. But then what happens is, it is not practical most of the time in the disadvantaged babies whose mothers are not fit to feed, or the babies are not fit to feed. So in such scenario, we used to depend on formulas all this while. And the only alternative when that is not available is PDHM, or pasteurized donor human milk. We now know that non-pasteurized sharing of breast milk bank is being discouraged by everybody because of the rise of transmitted infections and things like that, and medical legal implications. So you can only give another mother's milk if it is pasteurized and has gone through the set recommended patterns of screening. So the concept is now part of a larger plan by the World Health Organization called Every Newborn Action Plan, ENAP. And the government of India has adapted this to call it INAP, India Newborn Action Plan. And one of the base cost-effective feasible intervention suggested in INAP is the facility-based lactation management. And this is a new concept. It is not just exclusive breastfeeding or breast milk bank, it's a facility-based lactation management. And this is, of course, a major target intervention to reduce your infant mortality rate and morbidities to achieve our Millennium Goals and SDG. So, and the beauty is that this is effective in both resource-rich and resource-limited settings. And it's a three-tier approach that we follow in this. This is actually something that we should know. This is the future. So facility-based lactation management is a three-tier, vertical and horizontal three-tier arrangement, where you start right from the antenatal period. That's why for BFHI now we have expanded to MBFHI, and now we have mothers also involved, because until you train mothers and probably even pre-pregnancy, you make them aware of the benefits of breastfeeding, the whole program will not work. So breastfeeding counseling is given to pregnant women during the antenatal care. You initiate feeds early, and then you follow the dictum of on-demand feeding, no to formula, give enough lactation support, and add on the skin-to-skin care, an important part of facilitating both immunotransfer as well as promotion of lactation, or rather prevention of lactation failure. And when all these fail, these are the scenarios where donor human milk comes in handy. And in this facility-based lactation management, it has been suggested at a three-tier level. So the recommendation is each district should have one at least, and it should be a part of a comprehensive plan called Lactation Support Bank. And this should have ideally a lactation support center. The center of the lactation support center should be the breast milk bank. What does that breast milk bank do? It just collects breast milk, process it, and distribute it. Who can donate milk? Well, any healthy lactating mother in the postnatal wards can donate. And one of the areas where you can really motivate them is in the immunization clinics. Lactating staff of the hospital can be encouraged to set models, and mothers who have unfortunately lost their babies. All these are potential donors. Like all of you, those of you who were we were all students in the 80s. In the 80s, when we had when we started the blood donation forum and the blood donation drive, the awareness in Kerala was not much. So we used to go as medical students. We used to go around conducting camps in various clubs, telling them the benefits of blood donation. Now it's time to redo the whole thing, probably in a different way, to make the public aware of the benefits of milk donation. Because this is the way you are going to do the best service to the most disadvantaged of the neonatal group, the low birth weight, extreme preterm babies who have no other go other than to depend on PDHM when the mothers don't give milk. Now, there are some prerequisites for a mother to donate breast milk. Of course, good health, should not be in any medication except the vitamins, insulin, thyroid hormone. Of course, these are all known to you. I'll just elaborate the list. Usually what happens is mothers do have enough milk after feeding their own baby. So we don't say this. But now a particular company has come and started marketing donor milk. And now so many complaints have also started come and commercialization. Mothers being given incentive to deny breast milk to their own baby and sell breast milk. That is something we just cannot think of. We are not living in countries like Canada or UK where you get human milk ice creams and all that. We are not living in that age. Our mothers should be encouraged to donate breast milk to a charitable breast milk bank, not to these companies and not for commerce. So the incentives for donating milk also should not be of a material kind. So these are some issues which are still not defined in our IMS Act. we need to the mothers need to be willing to undergo screening, because you cannot afford to have any iatrogenic problems. So HIV, HBsAg, HBV, HCV, any pregnancy, all these are taken care of, so that is not a problem. And then ideally they should not be drinking tea, coffee and all just before donation. And 12 months you have to wait after a blood transfusion or a transplant. Again, that is for various other this thing as per the part. All these what I am saying are part of the IYCF and Government of India recognized guidelines for milk donation. There are some temporary disqualification also, like mastitis infection, alcohol consumption, caffeinated drinks, like vaccines received in the last 3 months, and then transplant blood donation 12 months. Again, that is again now disputed. With the new method of screening, probably the time window may come down. Now, what are the components of a breast milk bank? Of course, this is something probably new to some of us. I'll just take 1 minute, 5 minutes on this. You have an infrastructure, equipment and manpower. These are the basic 3 components. Little bit about infrastructure. The basic minimum requirement as per the Government of India rules and IYCF guidelines is a minimum of 250 square feet area should be dedicated for this, and ideally it should be close to the tertiary neonatal care unit ideally, and there has to be a separate expression room with privacy. There should be a space for record keeping. So 3 separate rooms are mandatory. 1 expression room, 1 is your lab, breast milk bank lab, where all the processing guns, and another one is the reception. And what we do, we have, this is the photo, this is our breast milk bank in Jubilee Mission Medical College. So we have the reception area doubles up for the record keeping also. So these are 3 areas which are mandatory. The equipments, you need to have refrigerators, deep freezers, pasteurizers, breast pumps, hot air oven, milk and so of these, the first 4 are essential, other ones are optional for you. The refrigerators you should have let me come in the order. So first you need to express milk. So milk expression is the first thing. Mothers should have a separate room for breast milk expression. They should be made to feel comfortable. Their consent should be taken, and after the gate, I'm not going to explain because of lack of time what all you need to do in that, but then only you need to remember that methods of milk expression remain the same, but hand expression is inferior to machine expression, especially if you want the volume of milk and if you want the high milk also. We also know first what you express is going to be a 4 milk. We want a high milk also. So, and now this is a very expensive pump, 3 lakh rupees pump, which we use in our breast milk bank, which where you can titrate the pressures at which the mother need to express and all that. But even a ordinary breast milk pump is also good enough. For ideally, just remember, for a term well baby mother expression, breast milk pump is not recommended, but for all sick high risk babies and preterm babies, mothers should be encouraged to buy a breast milk pump. That is the recommendation that has to be followed. And of course the methods and all, I'm sure it has been already discussed. How do we process this milk? We need to immediately refrigerate, and of course we have done the serology, we wait for the report to come, and pasteurization is the next step. It is a good practice to do microbiology before and after, but if you don't want to do it after pasteurization, you need to do a microbiology testing and colony count. If you are doing before pasteurization, less than 10⁴ to 5 is the colony forming units is the recommendation. Post pasteurization, no growth is acceptable. So if you are going to do random sampling, that like what we do in our breast milk bank, few batches you take samples and then you send it for culture to save cost. If you find even a growth, you have to discard. The problem is you have to discard the whole batch. Usually where the pasteurization is so effective, it doesn't happen, but this has to be recorded also, because we do not want, we are just embarking on this process of breast milk banking in our state. Now in the next few years, we don't want this program to fail because of the initial technical glitches. Now once you store the milk, once you refrigerate, if you are going to take time to pasteurize, you need to store it at -20 degrees. So you need a deep freezer. And after pasteurization, if you're going to take time to dispatch, again you need a deep freezer. So deep freezer has to be there in the breast milk bank for a longer storage of breast milk before and after pasteurization. And refrigerator also, you should have 2 refrigerators. We are having this is our refrigerator, one for pre and one for post. So like in the pre, you keep before pasteurization, it's better to have 2 separate, otherwise there can be a manual error of mixing. And so you keep it before pasteurization, you go to the pasteurizer. Once pasteurization is done, it comes back to the deep freezer, and after it is done before dispatch, you keep it in the post pasteurization. Now, hot air oven is not mandatory. It's a sterile service unit for the equipments. You can otherwise use the hospital CSSD and ETO method and all that. So, in hospitals, probably this is not mandatory. It's for standalone breast milk banks. This is mandatory. Now, pasteurization, little bit about pasteurization. There are 2 broad types of pasteurization. The one is the low temperature, long time pasteurization, LTLT. The other one is the high temperature, short time pasteurization. In human milk, we always prefer LTLT, low temperature, long time. In industry, milk industry, they do HTST. And the most common methods used, both are equally good, are Holder's method and shaker water bath. In Holder's method, what you do is, so anything more less than 115 degrees low temperature, the centigrade. So, say Holder's method, you use 62.5 degrees for 30 minutes. Shaker water bath, you have double walled steel chambers with microprocess temperature regulated timer device, and then the milk is kept in that, and then it is shaken. Milk is boiled through hot steam, and then tray is shaken and wobbled to avoid coagulation. Now, I will not go into more details unless somebody has questions about the methods of pasteurization, advantages of low temperature and high temperature and all. Just a bit of recent advances. Now we use, I said initially 62.5 degrees. People have tried higher temperature, but still in the LTLT, flash heat treatment, and try to look at whether that can be as good for 60 seconds. So the flash heat treatment is another method of pasteurization. And then the another method that is being tried, not the standard of care, is ultraviolet irradiation. Storage guidelines is similar to the usual guidelines. So this is the IBICF Indian guidelines, rule of 6. Breast milk freshly expressed, room temperature 6 hours, fridge 6 days, freezer 6 months. Once you pasteurize it, and when you thaw it, 4 hours in room temperature, 24 hours in fridge, and never in the freezer back. Thawed and warmed, again, until end of feeding, you can use it after this thing, and maximum in the fridge for 4 hours. These are IBICF. This is the American recommendation. Each breast milk bank system has their own guidelines. All of them are similar. I would recommend you to remember at least the rule of 6 and the Indian guidelines. Milk analyzer is one that is useful for analyzing the calorie, protein, fat using infrared spectroscopy. It's not mandatory. It is to ensure that the quality is maintained, but we know that quality is almost reasonably maintained. Now, thawing a little bit, it is a process of defrosting the milk for stored use. It's done rapidly in a water shaker bath at 37 degrees or below running lukewarm water. It's gently agitated to make homogeneous mixture before you're using it. Once you thaw it, you should use for within 4 hours, not 3 hours. That's the recommendation. And you never use microwave for thawing, because then the IgA will come down. That is because of the technology. And then never refreeze, as I said, after thawing, because that can precipitate the hydrolysis of triglycerides. Dispatch, if possible. This is again preferable method. We are living in a imbalance area of supply and demand. So probably if possible, preterm milk you use for preterm, and transport should be in cold chain if you are going to transport from one hospital to another one, and documentation should be perfect. Now a little bit about the quality initiative. People are trying to look at the mother's own milk versus pasteurized human milk. The biggest study again is from Brazil, and they have found that 6% reduction in protein and 8% reduction in fat. It's negligible. I think you should neglect this. When you don't have mom, you don't have a choice, you go for PDHM. Now, I know that the company that is promoting human milk is saying they do not have this loss of nutrients, they enrich the nutrients. But you have to think about the concept of bioavailability. Whatever you do in vitro and in vivo, there will be difference. So do not look at it. PDHM is definitely superior to the commercial human milk that you have. Vitamins and minerals are not affected, and long chain PUFA, DHA, they are all normal. So basically, you can take it as good. Only thing we now know, breast milk has something new concept, microbiome. So microbiota in the breast milk of mothers on milk may not be there in the PDHM. That is probably that you got to live with it. The two challenges before I wind up. One is, of course, meeting the shortage. This is a shortage, this thing, because we don't get enough supply of raw material, the mother's milk. The demand is too much. And now I just want to tell you one of the calls, interesting calls we had a month ago. One of the MPs from neighboring district of Tamil Nadu, Coimbatore, called. Somebody relative had a twin delivery and then a term baby, and they are asking for donor human milk. So anyway, that is stretching it too far. Let us at least start addressing the extreme preterm babies. Let us try to meet the demand by getting more, and pediatricians, obstetricians, public need to be created more awareness, and probably we need to get ourselves ready. To conclude, mom is the right of every baby, mother's own milk, whether it's term or preterm, but it might be impractical. There is no meaning talking hi-fi things when that doesn't work. In most of the level 3 NICU, which take care of 500, 600 grams, 26, 27 weeks babies, this problem is there. I face it every day. And then what is the only form? You need to use formula. That is the only thing, because we now know that starving the baby in the pretext of breast milk not available is not an option anymore. We don't want the gut to atrophy. So we need to go very proactive in getting more PDHM to meet the challenge. And ideally, when NNF Kerala collaborated with IAP and Rotary and all, and then we embarked on this project. And when we established, the idea was initially what we had initial discussion, we thought we'll have one breast milk bank in each district and then peripheral collection and distribution centers. But phase 2 is not ready. But I am very happy to say that Ravi sir and team, and along with Jayaraman sir and team, everybody is embarking on the phase 2. So probably we should have collection units now, and the banks that are working, they are just catering for only their own babies. We need to make them all the babies in the district, not only in their own hospital, should be provided. So these are the challenges ahead, and we need a proactive approach, practical approach. Don't talk on hi-fi things when the basic things you don't look after. So it is we should not have double standards. Let us go on and attack the problem right away, so that probably soon we'll get to this. Thank you. I have finished. Ready to take questions.